This is TTT Live. I'm DK Rostar. The Ministry of Health is giving an update on the status of COVID-19 in Trinidad and Tobago. We're bringing you live coverage on TTT, Talk City 91.1 FM, and on Facebook at TTT Live Online. We go now to the moderator, Al Alexander, Senior Corporate Communications Officer at the Ministry of Health.
Good morning and a pleasant and happy and prosperous new year to our viewing and listening public. It is a pleasure to be here with you at the first Ministry of Health's virtual media conference for 2021. Today on our panel, we have the Honorable Terence Dayal Singh, Minister of Health, Dr. Roshan Parasram, Chief Medical Officer, and Professor Christine Carrington, Professor of Molecular Genetics and Virology. I am Al Alexander, Senior Corporate Communications Officer at the Ministry of Health, and I will be your moderator today. The Honorable Terence Dayal Singh, Minister of Health, will begin this morning by providing the overview. Minister.
Thank you. Thank you very much, Al. Good morning to ladies and gentlemen of the media. Good morning to everyone who is listening or viewing. Very happy New Year from the Ministry of Health to everyone. And hopefully this year, and I am sure this year will be a much better year as far as COVID is concerned than 2020. What we are going to discuss this morning are a few things relating to where we are with the procurement of vaccines. But before I get into the particulars of vaccine procurement, we need to contextualize this whole discussion about vaccines as we deal with COVID-19 as a global pandemic. All around the world, we talk of vaccines and countries where vaccines have started to be administered. There is this feeling amongst the population that because you have a vaccine, whether you have received it or not, you can drop your guard. That you are somehow free of the virus, that your environment is free of the virus, your country is free of the virus. The world is not free of the virus by any stretch of the imagination. As a matter of fact, the daily caseload continues to be in the region of 650 to 700,000 cases per day. Absolutely no signs of slowing down. On October the 24th, at a press conference in Tobago, I first started to give the national population some idea of the countries that crossed the millionth mark as far as COVID cases are concerned. At that time, there were 7 countries in the world that had registered 1 million cases and above. Today, 2 months and roughly a week later, from 7 countries with 1 million cases and above, there are now 18 countries with 1 million cases and above. 18. So it has more than doubled. So there is no slowing down of the global pandemic. For those who follow regional news, you would have seen some of our CARICOM sisters and brothers having to implement very, very stringent measures to control what may be their second wave or their third wave or the end of their second wave. The fact is, our CARICOM area is not free of the virus. We in Trinidad and Tobago are relatively lucky. Globally, you would have seen the United Kingdom, France, Italy, Germany re-implementing very stringent lockdown measures. I just wanted to say that in the context of the expectation of a vaccine. We still have to continue with the public health measures. That is, wash your hands, social distancing, no large congregation in public more than 10 people, stay home if you are ill, and the usual public health measures in 2021 still apply. And even when we get the vaccine, hopefully in March, they will continue to be applicable. So, having said that, where are we globally? Globally, there are now 85,604,332 cases of COVID in the world. 85 million, closing in on 86 million. Deaths, 1,853,084. There are many countries in the world where their hospitals are running at 100% capacity and more. There are many countries in the world where if a non-COVID patient, for example, a cardiac patient, a stroke patient, wants an ICU bed, they cannot get one because their entire ICUs across their healthcare system has been taken over by COVID cases. Our parallel healthcare system has proven to be resilient, has proven to be strong, and I want to open 2021 by once again thanking, congratulating, and recognizing our healthcare workers. Where are we now with the procurement of vaccines? Trinidad and Tobago is procuring vaccines via two mechanisms. One, the COVAX facility, and two, outside of COVAX. As far as the COVAX facility is concerned, there have been some developments. There's a meeting tomorrow with WHO and PAHO and all CMOs of the region to talk about pre-qualification for vaccines for the region. This will address issues of which vaccines are being assessed, which have been approved, which are better candidates for our part of the world, our population. They will look at issues of availability, allocation, and access. We are also outside of the COVAX facility in talks, which I have said publicly, with individual companies like Pfizer, like AstraZeneca, and Sinopharm out of China bilaterally to look at the procurement of vaccines outside of COVAX. So we are pursuing two lines of procurement. Today at a meeting at our usual pre-press conference meeting with PAHO and the ministry, we have decided in the first part of phase one. So phase one of our vaccine procurement process will take place in 2021 this year. The first part of phase one, we have come up with an estimate of procuring 50,000 doses of vaccine based on a 2-dose regimen, which means in the first part of phase one, we are targeting 25,000 persons. That is the preliminary figure we have come up with to send up to PAHO tomorrow and any other company we are dealing with outside of COVAX. What is some of the rationale for going with 50,000 doses, which will vaccinate in the first instance 25,000 persons, remembering that each person has to get 2 shots? One, the expiry date of the vaccines so far, and everything I says has to be predicated on these 2 words, so far, things could change, seems to indicate a 6-month shelf life for the vaccines. 6 months. So it's not a very long shelf life. So we have to be cognizant of that. So we are hoping in the first part of phase one to go after 25,000 persons, which will include healthcare workers, some frontline workers, and the elderly in our long-stay facilities. Once we give that initial portion of doses to those hopefully 25,000 persons, we stop the vaccination program. We stop. And then reserve the other 25,000 doses for the second shot. Let me repeat that. Because the vaccination regime so far for both Pfizer, Moderna, and AstraZeneca is a 2-dose vaccine, one, a primer, and then in variant time lapses afterwards, it varies from vaccine manufacturer to vaccine manufacturer. Some it's 3 weeks CMO, some is a month, I believe. It means we have to reserve the equivalent number of doses for those same persons so they get their second dose. It makes little sense to give a lot of people the first dose, then you run out of vaccines, and then you lose the benefit of those persons having their first dose of vaccines. So that's the sort of quantities we are playing around with so far, based on the fact that so far the shelf life of the vaccines seems to be about 6 months. So when you have to reserve vaccines for 3 weeks to 4 weeks, it means you have lost a month. It means that second half of the vaccine just stays in a freezer, stays on a shelf, cannot be used. So in effect, you really have 5 months, really, to vaccinate people. So that's the thinking so far of ordering 50,000 doses to cover 25,000 persons. So that is where we are with vaccines so far. We are going ahead with all the other distribution parameters we need, cold storage chain, IT, communications plans, and so on. So that's the update I have for you this morning. Just to recap, the global pandemic has not slowed down. 2, with the advent of vaccines, it does not mean the public health measures have to be relaxed. We have to continue with them. 3, Trinidad and Tobago is pursuing the procurement of vaccines both within the COVAX facility and outside the COVAX facility. We are in talks, as I said, with AstraZeneca, Pfizer, and Sinopharm of China. To recap again, there's a technical meeting tomorrow, and that is where we are with vaccines up until this point, Monday, the 3rd of January, 2021. Thank you. 4th, sorry. 4th. The 4th of January, 2021. Thank you very much, Al, and over to you.
Thank you, Minister. We will move straight into the clinical update with Dr. Parasram.
Hi, good morning. Thank you, Al. Honorable Minister, Professor Carrington, members of the media, members of the viewing listening public, good morning and Happy New Year to everyone. So I will give the clinical update today as of Sunday, the 3rd of January 2021. So in terms of total number of persons tested thus far at both the public and private facilities, 72,623. Over the last 24 hours, we would have reported 6 persons being positive, new individuals. In total, since March 12th, we have 7,168 patients being positive confirmed. We have a total recovered number of patients, 6,690. Active cases now stand at 351, with a total of 127 deaths. And hospital patients now stand at 24. So I'll break down the hospital patients. So in terms of our total hospital load of 24, the majority are at the Couva Hospital and Multi-Training Facility, where we have 18 persons in the ambulatory ward, 1 in ICU, and that gives us an ambulatory total load on the system at 10% in the parallel system. Cora, 4 persons, all ambulatory as well. At the Scarborough Regional Hospital at the Fort, there are 2 persons, and there's 1 person en route to Signal Hill. With regards to our ICU capacity, we are 2% of confirmed cases. There's no one in the HDU who has been confirmed. With regards to our step-down, we have 66 persons in step-down. Just remembering, step-down persons are positive individuals who have either come from the community because of escalation of their symptoms, or they have come from another site, repatriation, for example, directly into those facilities with mild symptoms. So they are spread between Claxton Bay, where we have 17, UWI Debe, 46, and Tobago, there are 3 persons in step-down facilities. Lastly, in terms of our quarantine sites, we have 209 persons, with those persons would have been repatriated recently. The largest group of people are the UWI Canada Hall, 116, and at the Day Bay Hall we have 33. And we expect a flight coming in on the 6th of January 2021. That's our next flight for repatriates. And the other sites really have a low number of persons at this time, but we expect once that flight comes in, that those numbers will go up. So Al, that's my clinical summary for this morning.
Thank you, CMO. Now, some members of the public have expressed concerns about the speed at which these vaccines were developed and their safety. To bring clarity to these issues, I invite Professor Carrington to speak on how the COVID-19 vaccines were developed.
Thank you so much, Mr. Alexander, and good morning to Minister Dayal Singh, Dr. Parasram, members of the media and the viewing public. Now, vaccines save millions of lives each year, and the recent addition of the Oxford AstraZeneca vaccine and other vaccines to the world's anti-COVID-19 arsenal is very welcome. It's very welcome news, but on the other hand, there is concern about newly identified UK and South African variants of SARS-CoV-2, the virus which causes COVID-19, that appear to spread faster than other variants of the virus. And there's been a lot of discussion about the implications of this, and including whether the vaccines will protect against them. Now, the short answer to this is that while there is growing evidence that the UK and South African variants of concern are more transmissible, there is currently no evidence that they are more deadly, and there is no evidence that the existing vaccines will not be effective against them. However, these variants may be capable of spreading more quickly, so from a public health perspective, it is important to monitor them and to reinforce the need for all the usual non-pharmacological interventions, such as wearing masks, social distancing, and hand hygiene. Now, at the UWI, we recently implemented capacity for rapid virus genome sequencing, and at the request of CARPHA, the Caribbean Public Health Agency, we analyzed virus in diagnostic samples from Jamaica and showed the presence of the UK variant of concern, which has now been detected in 38 other countries around the world. We have also screened other samples provided by the Trinidad and Tobago Ministry of Health and by CARPHA for both the UK variant and the South African variants that are of concern, and so far we have not detected them in any of them in the Trinidad and Tobago samples. The UWI, of course, will continue to support the Ministry of Health and CARPHA with this monitoring and also with the incorporation of viral genomics and molecular epidemiological approaches into their COVID-19 mitigation and control efforts. So turning now to about vaccines and how they are developed. Now, a reminder, vaccines are biological preparations that train and prepare the body's natural defenses, that's your immune system, to recognize and fight off viruses and bacteria that they target. If the body is exposed to those disease-causing germs later, so having been vaccinated, if you're exposed to the targeted virus later on, the body is immediately ready to destroy them and to prevent illness. So that's how vaccines work. Now, in order to achieve this, vaccines contain a component that resembles the disease-causing virus, that it is training the immune response to recognize. And this component, it varies from one vaccine to the next. So this component may be, for example, a weakened or inactivated form of the target virus. And this is the approach that they use for the Sinopharm vaccine that was mentioned earlier. Or it may be the target virus's proteins, or it could be genetic material from the target virus that once introduced into the body and once it gets into a cell will be used to make proteins belonging to that virus. The Moderna and Pfizer mRNA vaccines are of this type. Alternatively, the vaccine component might be a totally different harmless virus that has been modified so it carries some of the proteins of the target virus or its genetic material needed to make those proteins. So every time what you're doing is you're introducing material into the body to trick the body into thinking it's been infected. But in fact, you do not get infected. Vaccines don't cause infection. They don't cause disease. Now, the Oxford AstraZeneca vaccine is of that last type that I mentioned. It's a viral vector vaccine. So whatever the type of vaccine, when a person is vaccinated, the result is that their body thinks it has been invaded and the immune response is triggered. Now, because the vaccine looks like the disease-causing virus, the tools that the immune system produces and remembers for the future will be effective against the real disease-causing disease-causing virus should you ever encounter it. Now, in terms of the speed at which these vaccines were developed, I'll just describe how vaccines are made and why it is we got here so quickly. So first of all, given the growing problem of disease emergence in recent decades, now disease emergence is not a new phenomenon. We've had SARS, we've had Zika, we've had dengue, we've had other viruses coming out, emerging in recent decades. So in light of that, when the COVID-19 virus emerged, scientists were already working on platforms for rapid vaccine development. So that's the first thing. They also had a lot of experience with previous coronaviruses. So for the SARS-CoV-2, the sort of initial exploratory phase that you go through in developing a vaccine was very, very short. And within days of the publication of the virus's genome sequence, the first candidate vaccines were developed. Now, the rest of the time has been spent on testing whether the various candidate vaccines are safe and whether they actually work. And this is done through very rigorous testing, first in preclinical trials done without human testing, and then many times in progressively larger phase 1, phase 2, and then phase 3 clinical trials. Now, in these trials, volunteers are divided into two groups, and one receives the candidate vaccine and the other one does not. They receive a control treatment for comparison. The groups are closely monitored, and data on their immune response, side effects, and any adverse events are recorded and compared. Now, before moving from one phase to the next, approval has to be obtained from panels of independent experts and regulatory bodies who review the results and check that there are no safety concerns, and they determine whether the immune response produced justifies further testing. So all of these vaccines have gone through this process. So it was all done for the COVID-19 vaccines. The process of development of the vaccines was accelerated in this case. These phase 1, phase 2, and phase 3 trials were accelerated because there was continuous monitoring of the results. So as soon as there was enough data to justify moving on to the next phase, they could do so. So you had overlapping phases, overlapping of the different phases as the vaccine was developed. Now, in the phase 3 trials, which are the last ones before a vaccine is rolled out, these involve tens of thousands of volunteers. Researchers will specifically test the efficacy of the vaccine. This is a measure of the extent to which the vaccine prevents infection or disease in vaccinated groups of people. So in the vaccinated group compared to the unvaccinated group. The closer that efficacy is to 100%, the better, but depending on the nature of the pathogen involved, lower efficacies can still be useful, especially from a public health perspective. And the WHO indicated that a minimum efficacy of 50% was acceptable for combating COVID-19. So without going into great detail, I just want to show you the efficacy data for 3 of the vaccines we've been talking a lot about, the Pfizer, the Moderna, and the Oxford AstraZeneca vaccine. So here's the first slide. This is for the Pfizer trial. They had 44,000 volunteers. And among those 44,000 volunteers, remember you'd have half vaccinated, half unvaccinated, there were 170 cases of COVID-19 in all. And of these, 162 were in the unvaccinated group and only 8 in the vaccinated, in the group that received the vaccine. So in this graph shown here, the red line in the graph, that shows how the incidence of COVID-19 increased in the unvaccinated volunteers compared to the almost flat line that you see for the vaccinated group of people. So you're seeing COVID-19 in the unvaccinated people and not in the vaccinated people. Well, at very, very, very low rates in the vaccinated people. These results indicate that the vaccine was 95% effective in preventing COVID-19, and they also found that there was almost 100% effective against severe COVID-19 disease. Next slide. So the Moderna vaccine, this is shown here, you see very similar results. They had 30,000 volunteers. The blue line in this case is the unvaccinated people, and you can see it going up. And the red line is the vaccinated people with very, very few cases of COVID-19. And in this case, the calculated efficacy was 94.1% against COVID-19 and 100% against severe COVID-19. The Oxford AstraZeneca vaccine now was tested in 4 different trials, some with slightly different dosing protocols. And the overall efficacy across the 2 groups of dosing protocols that they use was approximately 70%. So in this graph, the red line is the vaccinated group of people with very little COVID-19 compared to the unvaccinated people in the blue line. Okay, so you will see that from what I've shown there, determining the efficacy of a vaccine depends on knowing whether infections have occurred in vaccinated versus unvaccinated people. And ironically, the fact that the countries where these trials were carried out, the UK, the US, Brazil, the fact that those countries had such high levels of COVID-19 is one of the reasons why the vaccine was so quickly, why we were able to get these results so quickly. For other diseases, you may have had to wait for years to get to see the number of infections that would allow you to determine whether there's a significant difference between the groups. So that's one of the reasons, one of the things that's contributed to the rapid production of these vaccines. Now, people are interested in safety. When you have tens of thousands of people enrolled in a study, it is likely that a few of them will develop some sort of medical problem around the time of vaccination that has nothing to do with vaccination. So you have to be able to distinguish between what would have happened even if the person was not vaccinated and what is due to the vaccine when you're doing these trials. So in order that there's the best chance to identify even the most unexpected signals of possible vaccine-caused harm, amongst all of those chance events that happen to people every single day, during these trials, every single adverse event is collected and reported. It doesn't matter if it is a heart attack, if somebody stubbed their toe, if somebody was in a car accident. It's all reported, regardless of whether it is thought to be likely to be due to the vaccine or not. So after a vaccine is rolled out now, similar monitoring continues to enable scientists and public health bodies to keep track of and optimize the impact of the vaccines, to identify extremely rare events that may not have been picked up in the trials, and these are extremely rare events, and also to determine the long-term effectiveness. Now, I'm sure some of you have come across long lists of adverse events, or what they call health events, that were documented during clinical trials or after a vaccine rolls out. So you can get access to that sort of data. What you should know when you look at that data, so when you see 3,000 people have had adverse events, what you should know is those lists include true reactions to the vaccine as well as totally unrelated health problems. And that would have occurred even if the person had not been vaccinated. For the vaccines that I've mentioned, the true reactions to the vaccine, and this is statistically determined from analyzing the data, those have been identified as things like mild pain and swelling and redness at the site of injection. You can get mild fever, chills, headache, muscle and joint pain. And this is typical for vaccines. It's a typical response to vaccination. And all of this is actually an indication that your immune system is working and developing a protective immune response. And it usually occurs within immediately, or shortly after getting the vaccine, or within a few days. Now, for the Pfizer and Moderna vaccines, there have been a handful of people who have had allergic reactions to the vaccine. And these are all people with a history of severe allergies. And this is out of the hundreds and thousands of people who have been vaccinated already. Hundreds of thousands of people have been vaccinated already. So these are people who have a history of very severe reactions, some of them severe reactions to previous vaccines. All of the other severe events that were recorded during the trials of these vaccines occurred no more frequently in the vaccinated than the unvaccinated people. Okay, so they were probably occurring by chance. So what we have now is several very safe and effective vaccines against COVID-19. But as usual, until we get them, we have to continue with our social distancing, wearing masks, and washing our hands. Thank you very much.
Thank you, Professor Carrington. We now move to our question and answer segment, where members of the media are invited to pose questions to the panel. Happy New Year to our media representatives. You are reminded to state your name and the name of the media house that you represent, followed by your 2 brief questions. Please ask your questions one right after the other to the relevant members of the panel. Time permitting, we will allow a second round of questions where we will facilitate one question per media house. We will start the question and answer with CNC3.
Morning, everyone, and a Happy New Year to you all. So my first question is to Minister Dayal Singh. Over the weekend, we would have heard about a party that would have taken place in Tobago. So I'm just wondering if you're willing to comment on that. And my second question is to Dr. Carrington. Would you be able to go into a little bit more details about the genomic sequencing that you all are doing at the UE? More particularly, how is it that you all get these samples? Is it that when the samples are taken from people, everyone that is sampled, it goes to UE as well to sequence? And how may that interact with the antigen testing that we're hoping to implement in the near future? Thank you.
Thank you. Thank you very much, Rashad, and thank you for your greetings. Yeah. I will give you a general comment about the behavior of young persons between the age of 20 and 49 around the world. And you remember Dr. Hines speaking about this particular age cohort when we had community spread. It is that cohort around the world and their behavior and their feeling of invincibility that leads to the shutdown of bars and places of recreation. In addition to that party in no man's land, there was a All Year's Night fete in a warehouse in France where 2,000 young persons from England and continental Europe gathered. The police in France issued 1,000 tickets. But after a while, when they felt the situation was getting out of control and they didn't want to create a bigger problem with rioting, they just had to let those young persons go. The point I'm trying to make is that that cohort of people between the ages of 20 and 49 who still insist that they are invincible, whether it's in Trinidad, Tobago, France, the United States, university campuses around the world. It is that type of behavior which directly leads to those countries implementing severe lockdowns, shutting down pubs, bars and restaurants and nightlife. And it's sad. It's sad. Coming back to the no man's land issue, it happened. I am just hoping that the parents and grandparents of those young persons don't pay the ultimate price, which is dying from COVID. I just hope that those young persons don't go home now with that virus and infect their elderly parents and their grandparents, and also infect their school-age children. It's a global problem. It's a global problem. Talking to young persons. We had the incident in no man's land. You had the incident in France. You had the incidents all over the world. So we just have to keep appealing to people, not the party at this point in time. Thank you very much.
Professor Carrington.
So the genetic analyses that we're doing at UE doesn't interfere at all with the diagnostic process. When swabs are taken, nasal swabs are taken from individuals for diagnostic testing, the first step that happens, what happens first in the diagnostic lab, is that they extract genetic material from that sample. And that is what they use to do the PCR test to detect whether the virus is present or not. So when they extract that RNA, they don't need all of it for the diagnostic testing. They usually have excess, and that is stored in a freezer. And that is where we're getting our material from. So they will share that material with us. Now, by analyzing the genetic sequence of the virus in the sample, what we can do is determine the particular lineage of the virus that it belongs to. And there's a lot of other sort of molecular epidemiological a lot of inferences that we can make about the virus, how it is spreading, and how different lineages are connected and things like that. At the moment, well, we don't get all the samples. We don't have the resources to sequence every single sequence that we have in the freezers in Trinidad. We get a sample of them. And for example, since we knew that these UK and South African variants of concern were in circulation, and we know from the work done in other countries that they appeared first, thought to first have arisen in around September, for at least the UK one. What we did is we looked at the later samples. So we looked at some stored samples and we looked at some more recent samples. We are getting samples from the project is in collaboration with the Ministry of Health and with CARPHA, and so we'll be doing work to look at virus samples, not only from Trinidad, but from the rest of the region as well.
Fantastic news. We now go to CNC, Newsday. Newsday, we're ready for your questions.
Hi, good morning. Ryan Hamilton Davis, Trinidad Newsday. Just want to go slightly off topic here and speak a little bit about the cases that we've been noticing in the office here, that there's been a relative prevalence of below 20 cases per day for over the past week. So we were wondering if that signifies a decline in the number of cases, and well, what does the numbers suggest if not? And if there is a reduction in the numbers, is there enough of a reduction in numbers to suggest that the ministry could begin suggesting to reopen even further past what's already been reopened? Those are the two questions.
Okay, so yes, over the last week we would have had an average for the week of 8. The numbers are, we can't take it as face value at this point in time. We had a number of holidays and long weekends over the past couple of weeks. Traditionally the late December period in terms of persons' health-seeking behavior changes a little bit. So you find that less people seek care in the latter 2 weeks of the year, and this is beyond COVID. This is what we have seen in trends from years gone by. Persons will come in less often with mild disease into a hospital setting during that period. They'll probably wait until the first couple of weeks of January, of course, or if symptoms get more severe. I think what is more useful for us to look at this point, especially the last couple of weeks of December, is the occupancy levels in the hospitals, which we have been keeping a very close eye on. We're happy to report, again, as we reported this morning, that we only have 18 persons at the Couva Hospital in the ambulatory wards. There are 4 people in Cora. There's 1 person in the ICU, which is very good. So we anticipate, even if, and the number of deaths have gone down significantly as well. So we anticipate if there's some hidden pocket of disease, where it shows up in the hospital first. So we would like to take it with a grain of salt, if you want to use that word. For now, we look at it for the next 2 weeks and see what happens. Continue to sample those people that come into us voluntarily. Look at the numbers. Spikes usually show up 14 to 21 days after any particular event. So we have to monitor it for the most of January, see what is happening. If we're seeing the same trends, then we can review and suggest what can happen and should happen then. I know there has been an indication of certain things, for example, CXC examination occurring on the 15th, beginning on the 15th, and then a possible staggered reopening of some of the schools early on in February. So there are things that we have to consider, but we have to look at the numbers for another couple of weeks going into January, and then we can make some determinations as to what is happening.
Thank you, CMO. We now go to ACP News.
Hi, good morning. Private Harry, acpnews.com. Happy New Year to everyone. My first question is to Professor Carrington. Professor, some time ago at this very forum, Dr. Wheeler of PAHO said that she wanted to we should get vaccines that are more suited to our population. Has the UE, have you all decided which one you think is better suited to our population? And to the Minister of Health, as we look for other vaccines outside of COVAX, are we going to fill the deficit with those vaccines? And how much you think what percentage would we go outside, and at what cost are we looking at in terms of getting those vaccines?
Thank you, Prior. I will take both questions because the first question you asked is for the Minister of Health and not for Professor Carrington about which vaccine we will get in Trinidad and Tobago. So at the start of the press conference, I did say that there's a CMO's meeting tomorrow with WHO and COVAX to determine which vaccines are pre-qualified for the region, which vaccines are being assessed for the region that will be most suited to our populations, which vaccines are available, so that answers your availability question, and allocation and access. Some of those issues are being dealt with tomorrow at a high technical level with the CMOs of the region, with PAHO and COVAX. So we don't have specific quantities as yet, but as I said, our initial estimate to purchase in part 1 of phase 1 is to vaccinate 25,000 persons using a 2-dose regimen, which means we have to order 50,000 doses for part 1 of the first phase of the 2021 vaccination program. And those persons, just to be clear again, will be mainly healthcare workers, the elderly, especially those in long-stay homes, hospitalized patients, patients attending our outpatient clinics, and first-line responders, for example, police, and so on. So that's where we are with the answers to your questions. Thank you very much. And Prior, did you take your seasonal flu shot as yet? Prior? We go talk.
Thanks, Minister, for that clarification. I really do hope that Prior does take his vaccine pretty soon. We now go to Wired 868.
Hi, good morning, everyone.
Morning.
Happy New Year. This is Fayola Bostic from Wired 868. My first question goes to Minister Diyal Singh. Could you let us know what, you mentioned that the vaccines that we're looking at are all 2-dose vaccines, right? So the person has to come back after 21 days, I think you said. Could you tell us what methods are in place to make sure that the first 25,000 people actually return for their second dose? And what happens if they don't? Like, does the efficacy of their first dose become null and void, or what happens to the second vaccine that's being held for them? And my second question is, for the Chinese vaccine that you mentioned, what is the efficacy of that vaccine? And is that's not going to be procured through COVAX? So what is the agreement in place in terms of, do you know when we could expect, or is there a projection for when you expect to start getting these vaccines?
Okay, so let me refer to what I said at the start of the press conference. We are in talks with 2 mechanisms to procure vaccines. 1, COVAX, and 2, out of COVAX. For the vaccines out of China, they are in the COVAX facility, but we are also exploring separate talks with Sinopharm to purchase their vaccines once it is approved by WHO out of COVAX. So the Sinopharm vaccine is in COVAX, but we are pursuing bilateral talks once it is approved by WHO and so on, so that we could procure it out of COVAX. To answer your other question about ensuring that people come back for their second dose, so this morning, we normally have 2 detailed meetings on COVID before coming to these press conferences every Monday and Wednesday at 9:30 a.m. Before Christmas and before Old Year's, I would have asked for a detailed presentation on our IT readiness to do just this. How do we track persons? We got that presentation this morning, and we will have to possibly go out for an IT solution. The parameters have already been agreed to. The RFPs have already been agreed to. And how we could possibly do it by means of an app. So you come in on your first date, we will remind you electronically or a phone call or whatever that you need to come in 14 days later or 28 days later, whatever the case may be. What happens if you miss your second dose? I will let the Chief Medical Officer answer that because that's a technical question. So over to the Chief Medical Officer and possibly Professor Carrington.
So generally speaking, I mean, it's not the first group of vaccines we would have had with multiple doses. As you know, what the child vaccination program, which is DPT polio, there's up to 4 return visits for that particular vaccination. What the second dose of any vaccine is supposed to do is to give you an added boost, and that's why you call it a booster shot of your immunity. So for example, what is happening with Pfizer is that they are saying about 50% protection after 2 weeks when you get administration of your first dose, which goes up to around 91%, between 91 and 95% after you have the second dose. So the research that has been done thus far will tell you, based on the recommended dosing regime from the manufacturer. For Pfizer, if the case is that they recommend a dose 28 days later, what it will give you is 52% protection after the first dose, and of course 91 to 95% after the second dose. But what is happening if you miss that second dose? The one, we expect that there will be a boost of your immunity even if you get it late, which happens with other diseases, for example, measles, mumps, rubella. You do get some protection with the booster even if you come in late, you have a missed dose. So we recommend, even if you miss it by a week or two, that you still have it. But we will try to stick to the manufacturer's guideline because that is where the research is based. So we have research based on that dosing regime, and that is what we know. So we would expect that we try to keep people. However, if they miss the dose, we will still give you that dose as a top-up booster dose at a later date, hoping to get some degree of increase from the 52%, increasing it beyond. We don't know what that other number will be as you deviate from the 28 days.
I just want to come in here. I don't want the population and members of the media to get the impression we are doing all of this for the first time. Mm-hmm. We in Trinidad and Tobago and the CARICOM region and the PAHO region, South America, Central America, we have one of the most robust vaccination programs in the world. Mm-hmm. We are accustomed doing this mass vaccination program. We are accustomed delivering multi-dose vaccination regimes. So whilst I know the questions are needed, I just want to give the population the comfort in knowing we are not doing this for the first time. We are accustomed vaccinating children with a 2-dose MMR vaccine for years. We have mass vaccination programs in the CARICOM region, in the PAHO region for decades. So I just want to give you, members of the media, the comfort and the population that what we are doing is taking an already robust mass vaccination system and tailoring it to COVID-19 vaccines. Thank you very much.
Thanks for that clarification, Minister. We now go to TV6.
Hi, good morning, TV6. Hi, good morning, Vanessa Cutting, TV6 News.
Yes, morning.
Yeah. Could the minister indicate whether government is considering making it mandatory for any sector of the population, in particular healthcare workers, to take this vaccine? And also to Dr. Carrington, when you were speaking about the clinical trials, you noted that I think a small number of persons who had the vaccine did still contract the virus. Could you probably expound on this a bit more and say why this may have been, and also what percentage of persons that was?
Okay. Thank you, Renessa. So the short answer as to whether the government is considering making this mandatory, the answer is no. Why? One, we have a constitution, right to privacy. Two, there are some members of the population, because of inherent medical conditions, cannot be vaccinated across the board. Some children just cannot take the MMR vaccine. The people who are allergic. So you can't force a vaccine on someone for medical reasons and or to protect their right to privacy. So the answer is no, but it is going to be strongly recommended for all those persons in the front line and who are physically able and well enough to take the vaccines. Thank you very much. You raise an important issue.
Thank you, Minister. We now go to TTT.
Professor Carrington.
Professor Carrington.
Second question.
Yes, thanks. So you were asking about the numbers of people in the vaccine trial who actually got COVID-19. So remember, the trial would have, the one I gave numbers for was the Pfizer trial. There were 44,000 people in the trial, and of those, 170 got COVID-19. So when people are in a trial, they're not protected. These are people who are, given either the vaccine or a control treatment, and they go back to their normal lives, obviously with some information about how to protect themselves. But you do expect some of them to get the infection if they're in an environment where there's lots of COVID-19. So 170 people got COVID-19. Of that 170, 162 were unvaccinated people, and only 8 were vaccinated people. So what you're seeing is that the vaccinated people are protected much better. They are protected from almost, completely protected from the virus, and the unvaccinated people are not. Now, in the case of the Pfizer vaccine, that level of protection is 95%. If it was 100% effective, then you would have seen no one in the vaccinated group getting the virus. And this is not unusual. Vaccines not all vaccines give 100% protection. You can be vaccinated, and there's a chance that you can still end up getting the disease. But the thing is that you have to get as close to 100% protection as possible. What I should mention as well is that all of these vaccines have 70% or above efficacy, and the WHO is willing to accept a 50% level of efficacy. So these vaccines are doing very well. So it's the protection is is almost 100%.
Thank you very much, Professor Carrington. TTT, you're next.
Good morning, Head Table. Kimberly D'Souza from TTT News, and Happy New Year to everyone. My question is for CMO. Dr. Parasram, I was just wondering if you can give us more details about the repatriation flight. Do you know how many are coming in? Do you know what country they're coming in from? And also, do you know if there's any more onboarding to be done in terms of quarantine facilities, of course, as we continue the repatriation exercise? Thanks.
I could get the exact, I don't have the exact figure, but I know it's a mixed group of people, if I remember right. So some will be from UK and other parts of the world. We can get that off air to you if you like. Yeah.
So Kimberly, just to reiterate, we do know on the 6th, and we have had advance notice from the Ministry of National Security, that repatriation flight from the 6th does in fact contain some UK returnees. And as per policy, they are going to be quarantined for 14 days, those UK returnees.
Thank you, Minister. CL Communications, we're ready for your questions.
Good morning, Natalie Singh, CL Communications. I'm just curious, how likely are Trinidad and Tobago nationals to embrace this vaccine, given the side effects that have been published on the internet, and there are lots of articles and writings on it? And then secondly, Dr. Parasram, healthcare professionals are known to have developments around them. They will always have some new research, something new development. Bringing it back home to Trinidad, what have healthcare workers learned since this Trinidad's COVID-19's response? Thank you.
Okay, so I'll take your first question. We are going to be having a session with the media sometime at the end of January and February to deal with this same issue of reporting of side effects of vaccines. I am not, let me choose my words carefully. I am a bit concerned about the way the question was posed. Because when the research into these side effects are carried out, and I'll give you some, this is something coming out from the CDC. It is titled How People React to the Vaccine by Thomas Clark, MD, MPH, December 19th, 2020. And ladies and gentlemen of the media, we have to be careful how we phrase this issue of side effects. I always say the 999 things we do well don't get covered, but the one thing that goes wrong defines the public healthcare system. I don't want the same error to be made in reporting on side effects of vaccines. Yes, all drugs, even aspirin, even paracetamol, have side effects and can kill, but they are rare. In this report, it speaks to 6 cases of adverse reactions, all controlled, most of them in people who had pre-existing allergies. But here's the figure that doesn't make the headlines. Out of these 6 cases, 272,001 doses of the vaccines were given out, which gave 6 cases of possible side effects. So the learning has to be, when we are reporting on these very rare side effects, to also quote not the number of side effects, but the number of doses of vaccines administered, which gave rise. So just to reiterate, in this report out of the CDC, 272,001 doses were administered that gave rise to 6 cases. That is negligible, statistically insignificant, and the majority of cases were in people who already had a history of allergies. And that is why we are saying, and I said it on one of the TV stations last week, that people with known allergies should not access the vaccines. But we will be having a session with the media as to how to report on vaccines and how to report on these rare side effects that happen with any drug. Aspirin, paracetamol, ampicillin, penicillin. When you go to your doctor will ask you, are you allergic to penicillin? Every single drug does have side effects, including vaccines, however rare. So I just wanted to contextualize the answer. Thank you very much.
Thank you very much, Minister. And we'll take our last questions from the Express.
K. Marie Fletcher, Trinidad Express. My questions this morning is for Minister Dayal Singh. We know that the elderly is very high on the list to be targeted to receive the vaccines. Could you give us the total number of persons in geriatric homes in Trinidad and Tobago? And will their vaccination be voluntary or compulsory? My second question is, we know you mentioned that it's not mandatory to receive the vaccine.
So it's not compulsory. Sorry?
And, what about when the borders reopen? Would the vaccine be mandatory then for persons wanting to travel in and out of Trinidad and Tobago?
Okay. Thank you. So let me just reiterate. The administration of vaccines is not mandatory. We cannot force vaccines on anyone, whether it's a young person, a healthy adult, a healthcare worker, or somebody in a long stay home. Let me say that again. The vaccine program is not mandatory. It is not compulsory because of our constitution and because some may have legitimate medical reasons or other reasons for not taking the vaccines. You asked about the numbers. So this morning, we calculated the number. We estimate that in our long-stay homes, we have between 3,000 to 4,000 persons in our long-stay homes. There are roughly over 200 long-stay homes, and we calculated back of the envelope between 3,000 to 4,000. So those 3,000 to 4,000 elderly in those long-stay homes, together with healthcare workers, will be offered the vaccine in part 1 of phase 1 of the vaccine rollout. So I hope that answers your question. On repatriation. At this point in time, because we can't make vaccines mandatory, but however, individual countries, as you know, for example, yellow fever, you are not allowed to enter certain countries unless you are vaccinated against certain diseases. That may apply to COVID in the future. We don't know as yet. But there is precedent under international health rules that to get access to certain countries, you must be vaccinated for certain diseases. But that is an evolving issue, and we will look at it.
We thank the media for the engaging questions. We have reached the end of today's media conference. Thanks to everyone for your participation. As we close, we again remind you that we are still in the flu season. And my mind goes to the gentleman from EZP News. Please ensure that your entire family is vaccinated against the flu. Contact your nearest health center for details. Remember, get the vaccine, not the flu. Also, please remember to adhere to the simple guidelines that we at the Ministry of Health continue to reinforce. Maintain at least 6 feet apart from others. Stay home if you're ill. Wash your hands often with soap and water or hand sanitizer. Clean, frequently touched surfaces. And please, don't let them ask, wear your mask.